All right, I think we can get started. Thanks everyone for joining us today and welcome to this week's Grand Rounds. Please return next week for our special Jack Lassauer lecture given by Dr. Sonia Freeman titled Novel Therapies for Inflammatory Bowel Diseases. Today is our ICTR lecture at Medical Grand Rounds given by Dr. Aaron Rappaport titled Advances in Cellular Immunotherapy for Cancer, Impact of Point-of-Care Manufacturing. Dr. Rappaport is a hematologist and stem cell transplant physician who received his medical degree from Harvard and completed residency and fellowship training at University of Rochester. He's conducted translational research focused on the use of co-stimulated autologous T cells and vaccines to enhance immune recovery after autologous stem cell transplants for hematologic malignancies. He's led 6 major clinical trials of adoptive T cell therapy. His group was among the first to show that combination immunotherapy using vaccine prime and ex vivo co-stimulated autologous T cells could induce robust vaccine-specific immune responses early after autologous stem cell transplant for myeloma. They also demonstrated for the first time that early adopted transfers of co-stimulated T cells could induce robust T cell recovery post-transplant and elicit graft versus host disease-like reactions in the autologous transplant setting. In more recent work, he's described a novel combination of activated T cells, tumor antigen vaccine, and a novel vaccine adjuvant, which generated high frequency of tumor antigen vaccine-specific T cell responses greater than 70% after autologous stem cell transplant for myeloma. In another major clinical trial, they utilized high-affinity T cell receptor, gene-modified T cells for adoptive cellular therapy after autologous stem cell transplant for myeloma. These clinical trials have provided a new avenue for rapid reconstitution of T cell-mediated immunity following blood and bone marrow transplantation and laid the groundwork for the development of effective cellular immunotherapy for myeloma. Please welcome Dr. Rappaport.
Thank you so much. Thank you so much for the opportunity. Dr. Davis, Chief Medical Residence, thank you. So it's a pleasure to be here and share a little bit about what's going on in the area of cellular and immunotherapy for cancer and talk about some of the impact of our new lab. And by advances, I'm hope to talk about not only sort of new developments, new treatments in the field, but also some new discoveries. Let's see. So sort of being a clinician, I kind of like mnemonics, so I thought I would organize it according to the 6 T's of advancement in cell therapy, including discovery. But I'll start with some basics. The 6 T's will be timing of cell therapy, toxicities, phenomenon called trogocytosis, targeting, T cell receptor, and translational immunomonitoring. So I'll start with some basic principles of T cells. So, T cells interact with tumor cells and they engage with the tumor cell through a T cell receptor that recognizes an antigen in the context of HLA. And there are also a series of co-stimulatory signals that are delivered that then activate the T cell to proliferate and then and become enabled to kill the tumor cell. And then there are also counter-regulatory signals typified by the PD-L1, PD-1 interaction, that is the basis for checkpoint inhibitors, which block either PD-1 or PD-L1 or a related molecule called CTLA-4 that enhance endogenous immunity. Now, in terms of building a car, the first car was actually developed, pioneered by Israeli scientists Eleg Eshar and Gideon Gross at the Weizmann Institute in Israel in the late 80s and early 90s. The concept was to take the variable region of a monoclonal antibody and affix it to a signaling domain derived from the zeta chain of the TCR complex. And this worked in a variety of in vitro models and mouse models. And these were called T-bodies originally. But, before they could be really successfully applied to humans, they had to be modified, in particular, one or more co-stimulatory domains, either derived from 4,1-BB or CD28, had to be included in order to deliver an important secondary or co-stimulatory signal. These are the second generation CARs, and then there are also some third generation CARs that include two co-stimulatory domains, including in addition to the TCR CD3 zeta domain. And let's see, advance this one. There we go. And in terms of CAR T cell therapy in action, these cells interact with the antigen on the cancer cell through the CAR on the CAR T cell surface. And this recognition then leads to proliferation, activation of the cells, and the CAR T cells and/or their progeny are able to kill multiple tumor cells, leading to description of these cells as serial killers by Carl June, who was a longtime colleague and one of the pioneers of CAR T cell therapy, now at the University of Pennsylvania. Currently, there are at least 7 CARs in the garage. That is to say, there are 7 different CARs that are FDA approved for clinical use. There are 4 in lymphoma, including axicell, tisacell, and lysocell. These are all directed against the CD19 antigen on B-cell leukemia and lymphoma. But they have somewhat different co-stimulatory domains. Axicell uses CD28, whereas tisacell and lysocell use 4,1-BB co-stimulatory domain. There's also a modified version of axicell called Tecartus for mantle cell lymphoma and B-cell ALL. There's also a new kit on the block for relapsed refractory B-cell ALL called Obicell that is also directed against CD19 but has some different features. And there are also 2 CARs that are directed against BCMA, the B-cell maturation antigen on myeloma cells, namely Abecma, also known as ide-cel, and cilta-cel, also known as Carvykti. This just shows in general the general sort of approach. Patients undergo a steady state leukapheresis or apheresis to isolate the T cells. Sometimes they're separated into CD4 and CD8 compartments and cultured separately. There's a stimulation and expansion that goes on. There may be a role for some gene editing in investigational CARs. But there's transduction of the CAR using a lentivirus derived from HIV or retrovirus, or there can be non-viral transduction mechanisms as well. These cells then undergo culture and then undergo a period of quality control and clearance studies before they're ready to be returned to the patient, usually after a lymphodepletion chemotherapy. Now, as all of you know, all of the residents and fellows and ICU teams who've been involved in the care of these patients over the years, these cell therapies can provoke certain side effects, including CRS or cytokine release syndrome, which can have a variety of different manifestations, most commonly fever, changes in blood pressure, sometimes dyspnea, but many different organs, systems can be affected. These are mediated by cytokines, including particularly IL-6, IL-8, GM-CSF, interferon gamma, IL-1, IL-2. IL-6 is a very prominent cytokine involved. and in fact is the target of many of the treatments that we use, including tocilizumab, which is an antibody directed against the IL-6 receptor, steroids, but we also use a lot of other cytokine inhibitors nowadays, including anakinra against IL-1 and Jakafi against certain other cytokine pathways. Now, there is the other neurotoxicity, also known as ICANS, and this was a patient that we treated about 4 or 5 years ago, and it kind of shows the value of the serial handwriting samples that we do as a way of sort of picking up neurotoxicity. And you can see, name is Joni Baker, and she, gradually her handwriting deteriorates to the point where it looks like almost a ventricular tachycardia here. And but with treatment, including steroids, she did rapidly improve, and now she's, as I say, more than 5 years out from CAR T therapy and doing very, very well in complete remission. Now, some years ago, as a tool to help our hardworking residents and fellows and APPs, we developed a web app, a free web app called CAR T Cell Engine, that provides very user-friendly guidelines for managing CRS and ICANS. And this actually includes information for all of the 6 original CAR T products for lymphoma, leukemia, myeloma. It was developed with a UMMC innovation grant led by Tracy Douglas, our former colleague Saurabh Dahia, Kathy Rule, Jennifer Nishioka, and a number of other folks. And this is the logo for it. So many of the residents and fellows have this, but I'm just highlighting it so anyone who would like to download it on your phone, it's very easy to reference for managing CRS and ICANS. All right, well, let me turn to the 6 T's. The first T is timing, and so I think this has been an important finding, that the timing of CAR T cell therapy can make a difference. And this was actually 2 trials, including one that we were very active participants in, the ZUMA-7 trial, that looked at axi-cel in the second line. So historically, CAR T cell therapy for lymphoma was approved for third-line therapy, so after 2 failed prior lines of therapy. But a number of years ago, a very important randomized trial was conducted to look at axi-cel for patients who had failed 1 line of therapy, either primary refractory or early relapse of their aggressive lymphoma after initial therapy. And they were randomized to either go sort of directly to CAR T therapy or to get additional chemotherapy followed by an autologous stem cell transplant, which was the standard of care at the time. And in this study, the ZUMA-7 or the TRANSFORM study for liso-cel, clearly showed a much, much better progression-free survival for patients who went directly to CAR T therapy rather than trying to go through auto transplant, with much better event-free survival. And so for patients who have early relapse or primary refractory disease, CAR T therapy has essentially become the standard of care. But interestingly, when one looked at the overall survival was actually better for the patients who went directly to CAR T as well, rather than going through a transplant. And then those who didn't have a successful or a good outcome from transplant, or was not able to go to transplant, they did go through CAR T therapy. Many of them did, but that still wasn't enough to close the gap. The patients who went directly to CAR T therapy in the second line had a better overall survival that was sort of not bridgeable fully by going through third line CAR T therapy. So this really did emphasize, I think, the importance of earlier application of CAR T therapy for patients with relapsed or early relapsed or refractory disease. And whether this is due to more favorable disease characteristics, or whether it's due to better fitness of the T cells that you collect in the second line rather than waiting to the third line is a little bit unclear, but those may be important factors. In addition, in the myeloma space, very clearly, based on the CARTITUDE-4 study, CAR T therapy was much more effective than a standard of care therapy for patients who had relapsed refractory myeloma. That was a major finding there. But in addition, when one compared both the progression-free and the overall survival of patients who received CAR T therapy after 1 to 3 lines of therapy versus greater than or equal to 3 lines of therapy, there was better overall and progression-free survival, again suggesting, indicating that earlier application of CAR T therapy in myeloma is also potentially advantageous, maybe for the same reasons of catching the disease at a more favorable state, and or collecting the T cells when they're in somewhat better shape. So just like with aggressive lymphomas, we are using CAR T therapy for myeloma much earlier in the course of disease, after 1 to 3 lines of therapy, rather than waiting until 4 or more lines of therapy. So let me turn a little bit to toxicities, because, as you know, CRS and neurotoxicity are important side effects of CAR T therapy. And we've been trying to come up with some strategies for mitigating these toxicities. In one of the early studies, the ZUMA-1, there was a cohort of patients that was treated with prophylactic steroids and or early application of tocilizumab, which is the antibody against the IL-6 receptor. And this was associated with somewhat better, lower grade CRS, perhaps a delayed onset, perhaps a lower frequency of grade 3 or higher neurologic events. And this ultimately led to a study called ZUMA-24, which looked at prophylactic steroids to mitigate toxicity and also facilitate outpatient therapy. So patients received dexamethasone at day 0 when the patients received the CAR T cells, and then day 1 and day 2 afterwards. There were about 35 patients enrolled, 30 treated. We were also involved in this study. And the majority of patients had CRS, but almost all of it was low grade, grade 1 to 2. And the majority of patients did have some neurologic toxicity, but the grade 3 to 4 was relatively low at 23%. And the time of onset was somewhat delayed to 4 and 7 days versus the typical 2 and 5 days. ICU admission rates seemed to be lower. And there seemed to be no adverse effect on efficacy nor on expansion kinetics of the CAR T cells. And yet, this is, I think, not quite a home run. I mean, we haven't. This has not yet quite become the standard of care, but it does, I think, have a signal that there may be some role for prophylactic steroids, at least for patients perhaps with higher risk disease. Now, we've been doing. The University of Maryland was the 20th center in the country to be qualified to do CAR T cell therapy, and the first in the Delaware, Maryland, Virginia area to be qualified. So we've been doing CAR T therapy for almost 8 years now. But and as a result, there's now quite long-term follow-up, and there's some recent publications showing 5-year follow-up of standard of care CAR T therapy for large cell lymphoma. This came from the U.S. Lymphoma CAR T Consortium, which we were a founding member of, and it actually shows here the disease-free, the disease-specific survival, which is upwards of 50%. So after 2 years, very few patients have recurrences of their lymphoma. The 5-year overall survival is about 40%. the 5-year progression-free survival about 30%. And that is due to the fact that there are some later occurrences of non-relapse mortality, including infections and secondary neoplasms. This was particularly prominent in the not so much in the younger age group. This is less than age 60. This is greater than or equal to age 60. So really more in the older cohort of patients, there did seem to be a signal of later non-relapse mortality, again, mainly due to infections and secondary neoplasms. This highlights the types of infections that are seen, infection, sepsis. Certainly during the COVID pandemic, we did see quite a few patients who had rather severe COVID-related infections and complications post-CAR T. This led to some findings, some studies of ways to treat that and mitigate that, including an important publication using some interventions, including an agent called defibrotide that seemed to help certain patients who had very bad COVID-related pneumonia after CAR T therapy. But nonetheless, it is important that especially patients who are older than age 60, that we're very, very attentive to infections and to the potential for late-stage infections and infection-related deaths. Interestingly, late infections were not associated with neutropenia. Secondary primary malignancies, also an issue. A smattering of solid tumors have been seen in this cohort of patients from the lymphoma CAR T consortium. But the predominance, the largest numbers in the myeloid category, these would be patients with myeloid dysplasia, leukemia, or pre-leukemia. So this is an issue. Now, sort of trying to gain some insight into why this may be, it's many of these patients are, older. Some of these patients are heavily pretreated with prior chemotherapy and transplant, and these are factors that may, lead to the emergence of certain clonal disorders within the myeloid compartment that perhaps under the influence of CAR T-related inflammation may lead to evolution and ultimately emergence of a expanded clone of myeloid, altered myeloid stem cells that can then give rise to myelodysplasia or ultimately AML. So some of the strategies that we employ for mitigating late non-relapse mortality include the monitoring of IgG levels, because a proportion of patients, around 20% or so, do develop severe hypogammaglobulinemia that may be long-lasting. Often it mitigates, often it improves after about a year or so after CAR T, but we have some patients who are 3, 4, 5 years out who have very low IgG levels due to ongoing B-cell aplasia, B-cell depletion. And these patients may benefit from IVIG replacement, especially if their levels are less than 400 milligrams per deciliter. So we're very attentive to following that. Also, we're very careful about post-CAR T booster immunizations, especially seasonal vaccinations for influenza, COVID, and so forth. Importantly, a very important finding from Dr. Atanakovich in his lab was that even though these patients are B-cell depleted and don't mount a good antibody response to vaccinations, they still mount good T-cell responses. So that's an added sort of incentive or motivation to vaccinate these patients, even though antibody responses may not be that prominent. Now, also, we're very proactive about evaluating cytopenias that may be present after CAR T therapy to look for myeloid neoplasms, either MDS or AML. And there's been some evidence in the transplant space that that pre-transplant bone marrow evaluations looking for clonal disorders such as CCUS, which is clonal cytopenias of unknown significance, or CHIP, clonal hematopoiesis of indeterminate potential. These are low-level variants in known and genes associated with myeloid neoplasms. These may be potentially predictive of post-CAR T onset of myeloid disorders. Enhanced post-CAR T cancer screening, and as I mentioned earlier, application of CAR T therapy is advantageous in terms of outcomes, in terms of overall survival, and perhaps also could help to mitigate against later onset of secondary malignancies. Okay, let me start and then go turn to the third T, which is trogocytosis. Anybody besides George in his lab ever heard of trogocytosis? Okay, thank you. So a few, but it's a kind of it's a very interesting, strange phenomenon, whereby, you know, when the CAR T cell is interacting with the tumor cell, as shown here, there's what's called an immune synapse that forms a number of interaction of a number of surface proteins and ligands, receptors and ligands formed that ultimately can lead to the delivery of the killing molecules to the tumor cell, but it also can sometimes lead to transfer of membrane portions of the membrane from the tumor cell to the CAR T cell. And this is, the red shows the target antigens such as CD19 here. This is the CAR, and sometimes the T cell can pull off pieces of membrane from the tumor cell, including the target antigen, and that's what trogocytosis is. And in vitro, you know, it is quite clear that this occurs. This actually shows, this green, prominent green here, shows the presence of the CD19, which is the target for the majority of CARs that are approved for lymphoma and leukemia, sort of being transferred from these different tumor cell lines. These are all B-cell tumor cell lines being transferred to the CAR. This shift from the light peak to the prominent green peak is representative of that transfer. And by the same token, there's actually a bit of a loss of the tumor target, the CD19, on the tumor cell. And this is not restricted to CD19. This also occurs in the myeloma space with BCMA CAR T cells. You know, the issue is that as a result of the transfer of that target antigen to the CAR T cell, then you potentially are creating a situation where the CAR T cell may become susceptible to killing by other CAR T cells, so-called CAR T cell fratricide. And there's evidence that does occur at least in laboratory studies. Work by Tim Lutgens and Kenny Dietz here at University of Maryland have helped to understand that phenomenon and dive into it further, and they have made important discovery that cathepsin B, which is a cysteine protease, localizes to the immune synapse and contributes to trogocytosis, and a protease inhibitor called cystatin A can block the activity of this protease and reduce trogocytosis. Also, they have also shown that adjusting the affinity of the CAR for the target antigen, the CD19 CAR for the CD19 antigen, can also reduce trogocytosis. So that may be a way to get around that phenomenon. Now you may say, well, it's great, it happens in the laboratory. Does it happen in patients? And the answer is yes. This is work from George's lab showing that patients who received CD19 CAR T cells actually did acquire CD19 on the surface of their CAR T cells. These are, and this shows the sort of what happens with what's present on normal T cells versus the CAR T cells, and you see a rather big jump in some of the patients of CD19, the target for the CD19 CAR on the surface. So it does happen in patients as well. Okay, so the fourth T is targeting. So, as I said, the current FDA-approved CARs are right now targeting a limited scope of antigen, CD19 for lymphoma and B-cell leukemia, BCMA for myeloma. So it's a sort of a limited selection of targets. And one of the problems is that there's the potential, therefore, that when patients have relapses after CAR T therapy, that they may if they lose the target antigen, that may be a basis for escape from the CAR T cells. And in fact, that does happen not infrequently in the lymphoma CAR T consortium. We found that upwards of 30% of relapses had lost the target antigen, namely CD19, and so that was clearly a very likely mechanism of escape, and this is also true for ALL, and it's also seen in myeloma. So there's a notion that if you target more than one antigen, target 2 or 3 antigens at a time, maybe you would help to prevent that immune escape from occurring. So we're involved in a number of clinical trials looking at targeting simultaneously 2 antigens on B-cell malignancies or three antigens, and I'll talk a little bit about that. Also, I'll briefly mention the potential for new targets, including CD229, which was discovered by George and Tim Lutkins, and potentially as a target for therapy for myeloma and lymphoid neoplasms. So there's different ways that you could potentially target 2 or more antigens. You may make 2 populations of CAR T cells, one directed against CD19, another one against CD20 or CD22, which are also quite commonly expressed in B-cell malignancies. But this requires multiple production runs, and does one infuse them simultaneously? Might you get more, side effects like CRS? So that's sort of a potential problem with that approach. Then there is the idea of using a bivalent or bispecific receptor, where you've got the same stalk with the sort of the stalk and the signaling domains here, and then you've got the variable region for one, and sort of connected in cyst to a variable region for another antigen. So these are so-called bivalent or bispecific receptors. One potential thing you might imagine is there could be some, steric hindrance or some physical, interactions between these two that might compromise the ability of one of them to recognize a target antigen. And then you can also have co-expressions. You can have actually 2 stalks, 2 different CARs on the same cell, an anti-CD19 and an anti-CD20 or 22 expressed in the same cell. So these are called bicistronic. These are more sort of tandem or bivalent, and both of them approaches are under study. So this is a Kite 363. This is a study using a bicistronic approach, where we have a CD19 CAR that is simultaneously that is expressed in the same cell as an anti-CD20 CAR. And so the same vector, a vector that encodes both of these, is transferred into the T cell, and they're both expressed at the same in the same cell. So this actually shows the general treatment schema. Patients undergo leukapheresis, undergo manufacturing of this so-called bispecific CAR, And by Cistronic CAR, patients undergo lymphodepleting chemotherapy, then receive the infusion, and they go through the follow-up assessments. And this is actually a patient, describes a patient that we treated here at the University of Maryland who had, as an 84-year-old man, so emphasizing that CAR T therapy is really quite doable and quite successful in older adults. So an 84-year-old man at Chesapeake Bay Waterman, still working, who had actually received Axicell, which is the commercially approved CAR T for relapsed large cell lymphoma. But unfortunately, by day 60 after treatment, he had had progression. So he went on this clinical trial for the CD19/20 bispecific CAR. We recollected cells, manufactured the cells, and then he underwent another round of lymphodepletion and then received the CAR T cell infusion. He had no major side effects from it. And whereas the PET CT scan clearly shows, significant hypermetabolic lymphadenopathy here on the right, this disappeared by day 100, and he continued to do well for at least 6 months after CAR T therapy. Now, this was a study looking at a slightly different product, actually more of a tandem or where you have the CD19 and CD20 on the same stalk. And this is a product that is studied by a company called Miltenyi Biotech, which is one that we collaborate with. And this was a study of almost 60 patients who were valuable and who exhibited a rather favorable overall and survival and duration of response. And their incidence of side effects, the cytokine release syndrome and ICANS, was quite acceptable. And interestingly, this particular study included a CNS cohort. So patients who have either primary or secondary CNS lymphoma are not typically treated with CAR T therapy, or then it's not under the FDA label right now. Secondary is sort of, but not primary. But this particular study did include patients with CNS lymphoma, so we were able to treat a 77-year-old man who had primary CNS lymphoma and who came from the NIH, had gotten a very intensive regimen there. But despite that, had persistent leptomeningeal enhancement on MRI and also had persistent monoclonal B-cell lymphoma in the CSF. This patient, actually under a single patient IND that we had to obtain, received these tandem CD20, CD19 CARs called Zamtacell. And in our lab, in George's lab, we were able to show that these cells expanded rather dramatically by day 7. This is actually showing the presence of the CAR T cells in the peripheral blood, and also that these cells traffic to the CSF. So this was a CSF sample showing that the cells were getting into the CSF. And as such, starting day 7 after the CAR T, we no longer detected monoclonal B cells by flow in the CSF, and we've not detected them up till now 6 months after CAR T therapy. And when we looked at the MRI scan, this is pre-CAR T, you can see this leptomeningeal enhancement here that disappeared. Well, actually, this is both of these are pre-CAR T. You can see the leptomeningeal enhancement here and the parafalcine area and the frontoparietal area, and both of these disappeared. And he just had a 6-month assessment, and the complete response is maintained, is doing exceedingly well. So this was a demonstration that this new, bispecific CAR could not only migrate into the CSF, but actually could lead to a very impressive clinical response. Now, I'm going to turn here to the triple targeting. So if one is good, 2 may be better, maybe 3 is even better. So we're a little greedy here. So we now have the opportunity to target simultaneously 3 different antigens, CD19, 20, 22, all of which are widely expressed on B-cell lymphomas and leukemias. And this is our triple CAR approach. And this is actually a investigator-initiated study here at the University of Maryland, UMGCC 2372. This is a first-in-human study of this particular triple CAR approach. And not only that, but it is using point-of-care manufacturing. So we're actually making the cells here, right here in our GMP lab in the Bressler building at the University of Maryland. We've thus far have enrolled 3 patients and treated 1 so far. This is a fairly standard scheme showing that patients get enrolled. We collect the cells through standard apheresis catheter in our apheresis lab, and then actually while we're doing the manufacturing, because this is also a fresh in, fresh out product, we don't cryopreserve it. Patients undergo the lymphodepletion chemotherapy to make room for the CAR T cells to engraft and expand. And then on day 0, they receive the CAR T cells and then undergo, they're in the hospital for a couple weeks for monitoring, and then we undergo further assessments. And this is actually showing a picture of the so-called the Prodigy machine, which is an enclosed cell manufacturing system that we have in the lab, being operated by a couple of our team members. And this is where the cells were manufactured, right on this platform. We'll see more about that. This actually shows the star here actually shows the structure. For those of you who are molecularly oriented, it shows the structure of the vector that includes the CD20 and the CD19 that are kind of stuck together, and then they're on the same stalk with signaling domains of OX40 and CD3 zeta, and the CD22 is a separate molecule, and that has its own co-stimulatory domain and is expressed separate. So the triple CAR has CD19 and 20 on one stalk and CD22 on another stalk, but all 3 antigens are potentially recognized. And in our first patient, we were able to demonstrate not only engraftment, this is day 0, day 7, day 14, day 21, day 28 after CAR T infusion on our first patient. These are some control panels, but you can see here the engraftment, the expansion, and the persistence of these cells. And in fact, we've recently looked at both the peripheral blood and the bone marrow, and we see CAR T cells detectable as late as 3 months after CAR T, which is rather impressive. Now, going back to our earlier theme of trogocytosis, we do actually see some evidence of trogocytosis in this patient as well, where both the CD22, this is the red is the CAR, the blue is a non-CAR. You can see the shift in these peaks representing some transfer of CD22 to the CAR membrane, CAR T cell membrane, and the same happening with CD19. So we have a little bit that phenomenon going on with these triple CAR cells as well, and we'll have further studies will be indicating whether that will be an issue in terms of long-term response. But we did see a nice radiologic response for this patient. Had pre-CAR T PET scan showing some axillary adenopathy, hypermetabolic axillary adenopathy here that disappeared by day 60 and also is staying away as late as day 90. And so you may ask, well, what's the idea? What's the rationale for the point of care manufacturing? And it's kind of cool. It's fun. It's a very fun technology. But there's also potential for really markedly reducing manufacturing costs. The commercial CARs, CD19, CD20 CARs, CD19 CARs and BCMA CARs cost $500,000, all the companies, and the prices are trending upward. Our manufacturing costs are about 1/10 of that, so we can actually make these cells for about $50,000 in the lab. So that may be, that is a potential advantage. In addition, as you'll see in a moment, we can actually do some point of care testing of these cells to make sure that they're functional, to make sure that they are behaving as we would expect. That's not something that's typically done in commercial manufacturing labs. And also, as clearly you can see from our triple CAR experience, we're able to actually study and develop novel CARs in a good time frame. So this point of care manufacturing allows us to actually look at functionality. This is an example up here in the left upper corner of CAR T cells that we made in the laboratory that are secreting interferon gamma, granzyme B, TNF, which are all effector molecules by the CAR T cells. And this is a positive control, and then these are the actual CAR T cells here. So just illustrating that this does lend itself to some testing that may be valuable for CAR T evaluation. And also, I'd like to just briefly mention that in addition to targeting multiple antigens, 2 to 3, we can actually target potentially new antigens. So and this is CD229, which is a member of the SLAM family. This was actually discovered by Dr. Atanakovich and Tim Lukens, and done a lot of work. This actually shows a mouse model showing cure of a myeloma in a mouse model by CD229 CAR. We're in the process of moving this from the bench to the bedside. But this target is present not only in myeloma cells, but also many patients with lymphoma as well. And unlike the BCMA target, which is the current target targeted by commercial CARs for myeloma, CD229 is not shed. It's also expressed on myeloma stem cells. And so we're very, very excited about this future opportunity. And this was an example of a patient, an actual patient of ours who had been through BCMA CAR therapy, had done well for about a year, then had a relapse, and then I actually went through a couple of different bispecific antibodies and didn't respond to either of those. This patient's myeloma cells were very substantially killed, as shown here, by the CD229 CAR. So have a lot of hope for this target and for this future platform. Now, I just want to turn briefly to another T, the fifth T, which is T cell receptor. So this is another approach. CAR T cells have CARs, T cell receptors have TCRs, T cell receptors. And the advantage of TCR therapy is that it may broaden the tumor target. There may be, because many of the antigens are intracellular versus on the surface. And this was a study that we did a number of years ago in myeloma, looking at a cancer testis antigen, NY-ESO CAR, NY-ESO TCR, and about half the patients had responded. And this was one particular patient who had a PET CT scan that showed very extensive disease prior to the TCR, and post-TCR 1 week later was much improved, as shown here by this PET scan too. Here's a sternal lesion that disappeared, and you see these cells expand and grafted and expanded, and his myeloma markers dramatically improved, went from 4,800 kappa-free light chain all the way down to 2 at 3 weeks after TCR. So that really provided a proof of concept for TCR therapy. This is some subcutaneous tumors that regressed about a week after CAR. And this provided a platform for us to look at TCR T therapy in the solid tumor space. And this is a very extensive story, but just in brief, we had a young woman with a fibrolamellar liver cancer, which is a liver cancer associated with a particular fusion of 2 genes, one called DNA JP1 and PRA, and a protein kinase A gene. And this is a driver mutation for this tumor. And as a result of work that was started by a former colleague, Scott Strom, who I'm sure Dr. Davis remembers well, who had extensive tumor immunology experience in laboratory. We were able to pull out a T cell receptor that recognized this tumor target. And we were able to, through a series of IND-enabling experiments, develop an IND for the manufacturing of this TCR. And using the same Prodigy machine, we were able to manufacture these TCR T cells against this tumor. And this actually shows the magenta here actually shows the transduction, the transduced cells expanding and growing in culture. And by the time we collected them, we had a very large number of transduced TCR modified T cells that we could use for the treatment. So the last T is translational immunomonitoring core. So this is a laboratory that George Atanakovich and his colleagues Daniel, Ariel, and Rediet all run and staff. And we have a clinical research office, Pat, Ashlyn, Judy, supported by a clinical trial, IRB approved GCC 2043, to collect the serial blood, CSF, bone marrow, tissue samples from patients receiving immunofactor cell therapy. We've enrolled more than 200 patients, lymphoma, myeloma, leukemia, as well as some solid tumor patients. And this enables us to do real-time evaluation of trafficking, persistence, phenotypic, and functional studies. And I just want to show you a couple of examples of how this immunomonitoring core has really enabled. This is a patient who came in with a very, very high burden of myeloma, total protein level of 14 grams per deciliter. Normal is up to about 8, right? 14 grams, had a huge M spike that was totally refractory to therapy. He had massive expansion of the CAR T cells as shown in the peripheral blood that we were able to demonstrate in real time in the lab. This is a peripheral blood sample. More than 93% of the cells in his blood were CAR T cells, and his white count went up to as high as 60,000. And we were able to take his CAR T cells and directly show that they could kill a variety of myeloma cells in the laboratory. So that's sort of one example of some real-time information and functionality testing that we can do. In addition, we've have analyzed, done some real-world comparison of 2 FDA products for CAR T for myeloma here at the University of Maryland, namely the Carvykti versus Abecma, and we found some rather dramatic changes. The blue is the Carvykti, the cilta-cel, the red is the ide-cel. They have somewhat different structures and properties, and they have different patterns of persistence. And the cilta-cel, the Carvykti, has a higher level of expansion, and it's preferentially a CD4 versus the CD8 for the others. And this has a variety of other important functional and phenotypic properties. And the paper is now under a revision review at Nature Communications. So an example of the power of the immunomonitoring core that we have. This was from a patient who had an atypical CNS syndrome after CAR T therapy, a left facial nerve paralysis, and we were able to show some unique phenotypic properties. Clearly, the patient had CSF, had CAR T cells in the CSF, and we were able to identify some differences in the gene expression as well as the phenotype of the cells in the CSF versus the CAR versus the peripheral blood that may be impactful, may be responsible for the findings. But I also want to emphasize that the lab that we use to manufacture these CAR T cells is a shared resource. And we've done a whole variety of different projects in there. During COVID, we made COVID-related mesenchymal stem cells that were used in patients with COVID pneumonia, severe COVID pneumonia on ventilators. We've used it to make a cardiac stem cell product with a former colleague, Sanjay Kaushal. We've used it to do a CD34 selection of stem cells for patients who had graft failure after transplant and whom we had to do a second infusion of stem cells from a haplo donor, from a half-matched donor. And the only way we could do that was if we did a tremendous selection of CD34 cells and depleted the T cells. We were able to do that in that laboratory and with that technology, the Prodigy machine, and rescued three patients consecutively who had total graft failure. We were able to rescue their blood counts. And we have a variety of pending collaborations with colleagues from Johns Hopkins, surgical colleagues around islet cell, and also the potential of a virus-specific T cell manufacturing. So in closing, I'll just give you a kind of a virtual tour of the laboratory. We call it the FACT Lab, the Fanny Angelos Cellular Therapeutics Laboratory, because the initial gift came from Mr. Peter Angelos in memory of his sister Fanny Angelos. This is the layout. It's a five-room facility with a gown in, gown out rooms, two central cell culture rooms, and then a prep room and a transfer room. And each of these rooms has high HEPA filters that are working to create a very, very clean airspace, either ISO 7 or ISO 8, to minimize risk of contamination of cell products. This is a list of some of the equipment. This is actually the outside of two of the production rooms. This is what one of the production rooms look like. This is the other production room. And this is the transfer room showing our Prodigy machines housed there as well. So in summary and in conclusion, earlier application of CAR T cell therapy may yield better outcomes with lower risk of non-relapse mortality. Prophylactic steroids may reduce or delay side effects, including CRS and ICANS. Trogocytosis, the transfer of tumor antigens from the tumor cell to the CAR T cell, may impede CAR T efficacy by promoting T cell fratricide and reducing persistence. Targeting multiple antigens simultaneously may limit immune escape and allow treatment for relapses after FDA-approved CARs. TCR-T therapy is another important avenue for development, another way to target other tumor antigens. And I didn't mention this, but there's already an FDA-approved TCR for patients with synovial cell sarcoma called afami-cel that we are qualified to do. Point-of-care manufacturing may help with financial toxicities and allow development in real time and in good time frame of personalized as well as investigational cell therapeutics. And very important is it's very difficult to do any of this without a really good real-time immunomonitoring laboratory to guide clinical care management, evaluate toxicities, and facilitate new discoveries. And I also just want to highlight that, this work is, and this type of therapy can only be done with, it really takes a village to do this. We have cell therapy coordinators, we have inpatient, outpatient nurses, we have apheresis nurses, we have cell processing specialists, we have laboratories, we have, and of course, many residents and fellows who've gone through some of the training to become knowledgeable about managing CRS and ICANS. When we started this program 8 years ago, we had to train, and Dr. Shanholz can attest to this. We had to go through a training of hundreds of people because at that time we couldn't even start the program without anybody touching the patient having some knowledge and qualification in the evaluation and management of side effects. It's a little bit less burdensome now, but it still is important that all of our stakeholders, all of our team members have some familiarity. So I thank you for your time. I'm happy to take any questions, and thank you very much. To go to the next slide. Yeah.
Thank you so much, Dr. Rappaport. I know we're past our 1 hour mark, but if there are any burning questions from the audience.
Any concerns for tumor toxicities with the new CD229 CAR that you're aware of?
Well, it's a great question. I didn't even get into, off-target, off-tumor toxicity is definitely a concern for both CAR T and TCR-T therapy. I could go on and tell you a little bit about our early experience with TCR-T therapy, and talk about, the cardiac toxicity that we saw with an early TCR-T. But yes, it definitely is a concern, and that's why it's very important to do a very extensive preclinical evaluation. Some of the side effects that we see post-CAR T therapy, for example, for myeloma and the BCMA CAR, even using the FDA-approved commercial CAR, the atypical or some of the late-stage or atypical CNS effects, it seems to be due to the presence of a BCMA expression in a part of the brain, part of the cerebellum called the inferior olivary nucleus. So yes, I mean, that's definitely is a concern. We have done a very extensive study with the CD229 CAR and find it not to have any evidence of off-tumor, off-target, off-tumor expression. But obviously, one has to be very careful when one starts to use it clinically to look for that.
We have one last question. What is the total cost of a typical CAR T treatment for lymphoma using point of care manufacturing versus commercial?
Okay, well, so the cost of the commercial product is, as I mentioned, about $500,000. The cost of making it in a point of care fashion is about 1/10 of that, about $50,000. The clinical care is roughly the same, and approximates about $100,000 for apheresis, for chemotherapy, for inpatient, outpatient follow-up care. But yeah, there's a big difference in the cost of the products.
Thank you so much. Oh, we have one more question.
Fantastic talk. So I was curious about the triple CAR you mentioned. Is that something like that? Is it very challenging to design so that it's effective? And who designed the one that you're testing?
Yeah, that's a great question. So the triple CAR that we're studying is in a collaboration with Miltenyi Biotech, the company that makes the Prodigy machine that we use for manufacturing. And actually, in one of the slides I showed, there are actually 4 different triple CAR variants that were made. We were very fortunate to be a site for testing of one of those. Other centers have tested the others. I actually think we may have lucked out and gotten the best of the lot there. So, but yes, these undergo very extensive preclinical testing in the laboratory and mouse models to demonstrate that they have potential efficacy before they even get to human application. But we're very, very excited to be able to test this in our patients. Thank you. Thank you. Thank you. Thank you so much. I appreciate it.